Hello and welcome back to Mobile Health Industry Overview and the Evolving Regulatory Framework, a course offered by UCSF-Stanford Center of Excellence in Regulatory Science and Innovation. We concluded the previous module by presenting an FDA's oversight of mobile medical health. We reviewed medical device ADA system guidance and other guidances related to recent activity in the area of oversight of mobile health from the Food and Drug Administration and retraced some of the history, beginning with the FDA Asia LTC report and the several guidances that emerged from conversations and partnerships between the Food and Drug Administration and industry. Today, we begin Module 3. In Module 3, we will continue with learning about the oversight of mobile medical health with some advanced topics, including the role of the FTC, newest guidance on software as medical devices, and we will go deep into understanding the clinical decision support software and related guidance. We'll introduce new concepts related to the CDRH, relevant regulatory research priorities for 2017 and years after. We will conclude this module with plenty of examples of software with medical health management functionality. So let's begin this module by reviewing the role of the FTC in the oversight of mobile medical health. We ended the previous module with examples of digital mobile health companies that saw the intervention of the Federal Trade Commission and not of the Food and Drug Administration or matters pertaining to the company's health claims to consumers. And I promised we would continue the discussion here in Module 3. As you may remember, among others, I mentioned the case of Lumosity's brain training program. The Lumosity consisting of some 40 games. Only in 2016, the creators of the program agreed to settle charges by the Federal Trade Commission, alleging that they deceived consumers with unfunded claims. So what happened exactly? In January of 2016, the FTC charged Lumos Lab, the company that marketed Lumosity, with making claims that were not supported by science, including claims that using Lumosity, for example, would improve performance in school, work, and athletics, would delay age-related mental decline, and protect against dementia and Alzheimer's disease, and would help those with ADHD, PTSD, traumatic brain injuries, and other diseases. And specifically, what Lumos Lab's promise was that these benefits could be achieved by students, athletes, and people with medical conditions simply by playing Lumosity games for 10-15 minutes several times a week. The FTC alleged that Lumos Labs made a host of false and deceptive representations, including that scientific studies prove that training with Lumosity provides its benefits. And the FTC also charged that the company failed to disclose that it solicited testimonials on its site as part of a contest. This was an expensive lesson for Lumos Lab, which agreed to pay $2 million to settle the charges. It was also a very good one for the rest of the industry. The Lumosity settlement was the latest in a series of cases reminding advertisers that claims need solid scientific support, and that material connections, in other words, prices, between an advertiser and an endorser must be disclosed. Perhaps one of the most interesting takeaways on the part of industry was that FTC would intervene even in situations when everybody would have expected the FDA to take action. In this particular case, it seemed relatively clear that the Lumosity program is a medical device, and yet FTC still took the lead. No one questioned the fact that FTC had the right to enforcement. Obviously, it had a right to enforcement, and the FTC has long been at the forefront of consumer privacy and data security, including issues arising in the mobile health arenas. It was the silence from FDA that some opinion leaders in the space found somewhat surprising. If you're interested in reading more about FTC's enforcement actions in the mobile health space, I encourage you to search the Federal Trade Commission website for a few additional cases. Here is one from 2015, when the Federal Trade Commission has challenged 4 marketers for deceptively claiming their mobile apps could detect symptoms of melanoma, even if it's early stages. According to the complaints, each of the apps instructed users to photograph a mole with a smartphone camera in order to receive an assessment of melanoma risk, without adequate evidence to support these claims. In another more recent case, at the end of 2016, marketers of a mobile app designed to measure blood pressure have agreed to settle Federal Trade Commission charges that they deceived consumers who claims that their instant blood pressure app was as accurate as a traditional blood pressure cuff. In reality, however, blood pressure readings reported by the app were significantly less accurate than those taken with a traditional blood pressure cuff. And to use the company's app, users put the right fingers over the phone's rear camera lens and held the base of the phone over their heart, with again, very little, if nothing, to support that this use was established in scientific evidence. Further solidifying the role in mobile health, the Federal Trade Commission in April of 2016 released a web-based tool for developers of health-related mobile apps. The tool asks developers a series of high-level questions about the app's function, the data it collects, and the services provided to users. Based on those answers, the tool will point the app developer towards detailed information about certain federal laws that might apply, including the FTC Act, the FTC Health Breach Notification Rule, and the Health Insurance Portability and Accountability Act, which will be a subject of this course in a later module. In addition, FTC simultaneously released its own business guidance aimed at helping health app developers complying with the FTC Act by building privacy and security into their apps. If you're interested in developing a mobile health app, it's a great resource and an easy-to-consult one that offers some very practical bits of wisdom. For example, always start with security. Control access to data sensibly. Require secure passwords and authentication. Store sensitive personal information securely and protect it during transmission. Segment your network and monitor who's trying to get in and out, and secure remote access to your network. Apply sound security practices when developing new products, and make sure your service providers implement reasonable security measures. Before we conclude this section of Module 3, I'd like to point to some interesting recent developments, beginning with one that occurred in March 2017, when the New York Attorney General's office settled with 3 mobile health apps it alleged were misleading consumers and engaging in questionable privacy practices. The apps, which include Adidas subsidiary Runtastic, MIT Media Lab spin-off Cardios, and My Baby's Beat, all claim to monitor the human heartbeat using only a smartphone's camera or microphone and some proprietary algorithms. This is interesting because yet again we have an agency other than the FDA, and here other than the FTC, weighing in on what it thinks it's misleading advertising. Indeed, the federal government doesn't have a monopoly on regulating advertising, even for health-related products. Most states have agencies that oversee advertising within their state. And this recent settlement reminds developers of apps to think about their claims very carefully, in that an enforcer in any state might take offense, without relying on the federal government, either the FDA or FTC, to take appropriate actions. Also noteworthy is the news of the Enhanced Oversight and Accountability Final Rule, released by the Office of the National Coordinator for Health Information Technology, ONC, in October 2016. You probably remember the ONC from my brief introduction in Module 1. But in case you don't, we're talking about the staff division of the Office of the Secretary within the U.S. Department of Health and Human Services, which is charged with coordination of nationwide efforts to implement and use the most advanced health information technology and the electronic exchange of health information, a very broad technology area which overlaps, at least in part, with mobile health. Now, the final rule, released in October 2016, updates the so-called ONC Health IT certification program with provisions that are intended to allow direct review, enhance oversight, and increase health IT developer accountability. The final rule also focuses on corrective action plans to address issues and includes an appeal process. I'd like to now place a regulatory framework for mobile health in the context of the later regulatory development pertaining to the broader digital health and health information technology, also known as Health IT or simply HIT. To do that, let's begin by breaking down the broad areas of digital health with emphasis on mobile health and on Health IT in three main clusters of technological development. At the top in this slide are the technologies facing the enterprise, including and especially the hospital. These include analytics and software for risk management, as well as electronic medical and health records, or EMR and EHR respectively. Notably, the software tools started to streamline simple administrative tasks, such as filling out forms and processing billing requests. Increasingly, however, the enterprise world is becoming very connected, with the software tools interfacing a growing number of life-saving and life-sustaining capital medical equipment, as well as wirelessly enabled mobile medical devices. In the middle cluster are workflow and productivity software and devices, such as tablets and monitoring or control software. And think as an example those that nurses depend on for data management on individual patients and for patient surveillance on the care floor. On the bottom cluster are all the technologies in the space that are typically direct to consumers or used in the home environment. There's been some very interesting changes in the space. The first one is that enterprise management software technology, initially developed for administrative tasks, is evolving very rapidly. Not only the hospital is increasingly reliant on these networks, it is also increasingly dependent on its software and data for clinical management. In other words, for the practice of care. As a result of these needs, we're seeing enterprise management software technologies expanding to more and more data mining, to benchmarking applications, effectively establishing standards of practice, and increasingly providing real-time access to predictive algorithms. In the meantime, workflow and productivity software and devices for the hospital and patients, as well as apps, sensors, and monitoring devices for the home and consumers, are becoming very sophisticated. With more real-time data exchange and control capabilities at increasingly affordable cost, and the proliferation of general wellness technologies, the boundaries between health and medical are not always clear. And there is a very clear push towards vertical integration, with hospitals beginning to recognize clinical utility in some of the data that is generated within the home. The Health Information Technology for Economic and Clinical Health Act was a definite push for these trends. The act, known as the High-Tech Act, was enacted as part of the American Recovery and Reinvestment Act of 2009 and was signed into law in February 2009 to promote the adoption of meaningful use of health information technology. It was the first in a series of key healthcare reform legislation spanning 5 years, including the Patient Protection and Affordable Care Act of 2010, Medicare incentives for accountable care organizations that came in effect in 2012, and the launch of healthcare.gov shortly after. Federal initiatives sought to reduce the costs and streamline processes, and digital health, especially health information technologies and mobile health, have been on the forefront of this healthcare transformation. Reform policies have incentivized a new wave of technology solutions, as well as business models, by creating tens of billions of dollars in incentives for healthcare providers to implement federally approved information technology systems. Understanding that these trends are to continue, the quick question every digital health technology manufacturer is asking is this one. So what does the FDA want to regulate? The FDA has consistently said and shown that their approach to regulation of technology in health information technology and the broader digital health is based on functionality. And in response to the technological evolution in the industry, it has laid out its own segmentation based solely on the particular claims that such technologies are making. On the left are technologies with pure administrative functionality, admission, billing, and claim processing, for example, which is what electronic health records were in their purest form when they were first introduced. In this category are also some functionalities related to population health management, as it impacts public health policy and quality measure reporting. On the right are technologies with medical device functionality, as could be, for example, software enabling computer-aided detection or diagnosis based on patient data, including images. These are the kinds of functions that the FDA has traditionally regulated and intends to continue to. In the middle is the most interesting category for our purposes, health management functionality, including SINON software known as clinical decision software, which we'll be talking about more extensively in the continuation of this module. Now, as mentioned, FDA intends to obviously continue to fulfill its mission with regulatory oversight of medical devices. And it has also made very clear that it has never had, nor it intends to have, oversight of devices with administrative functionality. The middle bracket is most interesting to us because it's less straightforward. FDA does not intend to focus its oversight on health management functionality. And most health management functionality is now going to be regulated. But where is the line between that and regulated medical devices? That is what the FDA has been working hard to define in the past recent years. And the work is ongoing, recognizing that industry needs more specific from all of the agencies and stakeholders. What the FDA has done is it has laid out 4 key priority areas for health management, and these are to promote the use of quality management principles, to identify, develop, and adopt standards and best practices, and to leverage conformity assessment tools, as well as create an environment of learning and continual improvement. Obviously, in that middle health management category is a broad spectrum of possibilities, where there are some areas where a more formal governance procedure, whether it is industry-based or private-public or led by the ONC perhaps, is actually quite helpful and appropriate. And then there are other areas where industry or some of other sort of less formal best practices approaches are perhaps most effective. Either way, there is a health IT ecosystem working collaboratively together to have a framework in place and the ongoing success. One perhaps lesser known player in this collaborative ecosystem is the International Medical Device Regulators Forum, IMDRF, which is a global voluntary group of medical device regulators conceived in February 2011 to discuss further direction in medical device regulatory harmonization. The group builds on the foundational work of the Global Harmonization Task Force on Medical Devices and includes in its management committee regulatory authority representatives from the FDA and other agencies around the world. Jeffrey Shuren, who is the director of FDA's Center for Devices and Radiological Health, is in fact chair member as of 2017. Please note the IMDRF is not working on just the topics of interest to this course. The slide offers a snapshot of open work items as of the spring of 2017, and as you can see, they span several topics beyond mobile health and the broader health IT. For example, in a recent meeting, the IMDRF members discussed various topics ranging from the introduction of a new risk-based classification system from in vitro diagnostics to a new European-wide requirement for an implant card to be given to patients receiving implanted devices. The reason we're talking about the IMDRF is that the forum has been working also to establish a common framework for regulators to incorporate converged controls into the regulatory approaches for software as a medical device, recognizing that, 1, software is becoming increasingly important and pervasive in healthcare, and 2, whereas existing regulations address public health risk of software but when embedded in traditional medical devices, the current application of regulations and controls may not always translate or address the unique public health risks posed by software, and is at the moment one of the areas of great uncertainty, especially when it comes to understanding boundaries between medical and non-medical purpose.